name is Gladys. I'm a midwife from Uganda, and I think today is our first lesson since the year began. And I want to start by saying Happy New Year to everyone. Today we are going to handle a topic as antepartum hemorrhage, and this is basically under maternal and newborn nursing too. So we are going to start with our objectives. So the learning objectives for today is to define antepartum hemorrhage, which we abbreviate as APH. The second objective is to define placenta previa and abruptio placenta. Our third objective is to identify the risk factors and signs of these conditions, as having mentioned in our second objective, and then to explain the diagnosis and management of these conditions. And lastly, we have to discuss the implications for maternal and fetal outcomes. So we want to start with a definition of antepartum hemorrhage as our introduction. So antepartum hemorrhage, as abbreviated APH, is bleeding from the genital tract after 26 weeks of gestation and before onset of labor and delivery. So you realize that we used to consider 28 weeks. But now, in relation to the different nursing care that we provide to our newborn, we have decided in the Western countries, you realize is 24 weeks. So what could be the causes of antepartum hemorrhage? Having mentioned that is bleeding from the genital tract after 26 weeks. So if it is bleeding before 26 weeks, that is an abortion. In case the woman releases the pregnancy around those weeks, below 26 weeks, then it can be called an abortion. But a child or a baby, a newborn who is delivered within the 26 weeks is expected to survive. So that one is called a preterm delivery. So the causes of postpartum hemorrhage are abruptio placenta, placenta previa, and ruptured uterus. So some of us interface with some of these conditions as with mothers, and we realize that when they are bleeding, the baby is still inside, they have not yet delivered the baby, and that's why they call it antepartum hemorrhage. Other causes can be, besides what we have mentioned, the first three, there can be also other causes, and that is vasa previa, whereby there will be wearing down or tearing of the blood vessels around the genital tract within the cervical os, and the mother can easily bleed. So when the bleeding occurs due to the injury breaking of those blood vessels within the cervical os, then we can call it vasa previa. Then bleeding from the low genital lesions, it can be due to cervical ectropion, and also it can be due to cervical polyps or vaginal vessels. There can be various symptoms. So it's basically looking at the blood vessels within the genital tract when they get engorged and then they rupture, they can also bleed. Then cervical cancers also cause bleeding. When a woman is pregnant and she bleeds and she has cancer, it can be due to cervical cancer. Placenta previa and abruptio placenta. You realize that placenta previa is just a condition that is characterized by bleeding from a partially separated placenta that is either located wholly or partially in the lower uterine segment, or it refers to the painless vaginal bleeding due to low-lying placenta after 26 weeks of gestation or before delivery of the baby. So it can be around 24 weeks, or it can be even the time when the mother is in term. So term pregnancies are basically from 27 weeks of gestation. So the mother can easily start bleeding around that period, and yet the baby is still in. She has not yet delivered it, so we call it placenta previa. So you can look at this diagram. You can see how the placenta is located and how the babies are lying, and you can see placenta previa and abruptio placenta, but this one is basically explaining about placenta previa. So the normal placenta is supposed to be located on the upper segment of the uterus, and you can see on this other picture on this side, this is the placenta around here, and then this is the umbilical cord, and this is our baby. So these are the uterine walls. Around this, surround the baby is the uterine wall, and then we have the cervix over here. So this is the head of the baby, which is the one that is presenting. So the placenta is supposed to be located at the upper segment of the uterus. When it is located at the lower segment, then we shall call it placenta previa. So when you come to this other side, this there when you look at on your upper segment of the uterus, but when you come to this other side, you find this baby is lying on top of the placenta. So this is the placenta which is located at the lower segment of the uterus and is covering the cervical os, whereby to be preventing this baby from descending to be delivered. So this is already a problem when the placenta is located at the lower segment of the uterus. So this is called placenta previa. So placenta previa basically is the incidence varies between 1 in 200 to 1 in 300 deliveries. So you realize it is something that is rare. It's a condition that is rare. It is not a very, very common condition. But when it occurs, of course, it needs an emergency attention to the mother because we can easily lose the mother because of severe bleeding. The risk of reoccurrence is also the next pregnancy is about 5%. So if a mother has ever had placenta previa, she's likely to also get it in the next other pregnancies. So when a mother comes to you and she tells you that she had placenta previa, you have also to take note. This mother can easily get again another placenta previa condition in the next pregnancies. So it is about 5% reoccurrence. So the types of placenta previa basically is the placenta previa is divided into 4 types or degrees. So we have the normal placenta as you see it. Then you have the low implantation. The low implantation is this one in the second, whereby the placenta is actually implanted at the lower segment of the uterus. But for it, it doesn't touch any part of the cervix, but just at the lower segment of the uterus. So this mother can easily deliver this baby because it is not covering the cervical os. Then when you go to the third picture, as you see it, the baby is actually in a breech presentation. You see the buttocks are here, down, and this could be even the cause of the placenta previa. I mean the cause of the breech because there was a placenta down. So this is a partially placenta previa, whereby it is just at the edge is just at the edge of the cervix, but has not covered the entire os. Then when you come here, this one is the total placenta previa. It has covered the entire os of the cervix. So this one is already putting this mother and the baby in danger because it has covered the cervical os. So the different types, as I've mentioned, can be explained. So type 1, placenta in the upper segment. So the placenta is basically at the upper segment, but in lower margin, it's into the lower uterine segment. So it is a low-lying kind of placenta. For it, it doesn't reach to the os, and it doesn't even touch the os, the cervical os, but is at the lower segment of the uterus. Then the type 2, partially situated in the lower uterine segment. So the lower margin reaches to the edge of the internal os. This is the marginal placenta previa. So they say marginal because just at the margin, at the edge of the cervical os, which has not covered the whole os, but is just at the edge of the os, and that's why it is called the marginal placenta previa. But you look at this type 2, it has two different types also. Type 2 is divided into two. We have placenta previa, which is anterior, and then placenta previa type 2, which is posterior. So later we shall understand the different two types of type 2 placenta previa, what is related with the anterior and what the posterior is all about, and how do they affect a normal delivery. How does type 2 anterior affect normal delivery, and how does type 2 posterior affect normal deliveries? So type 3, this one covers the internal os. When it is closed, up to 3 to 4 centimeters. So it is some kind of placenta whereby it covers the os, but when the cervix is closed, you will really touch that and you feel that there is a cervical, there is a placenta around the os, around the cervix, but when it dilates, it moves off the placenta from it and it doesn't actually cover the entire os. But when you go to the complete placenta previa type 4, in this type, the placenta completely covers the internal os, even when the cervix is fully dilated. So this is the most severe form of kind of placenta previa, whereby the mother can never be put at risk of any kind of attempt to deliver vaginally because she will bleed. As long as the cervix starts to dilate, it will cause the separation of the placenta and the mother will bleed profusely and we can easily lose that mother. So we have different types of placenta previa, and those different types of placenta previa also give us different ways of management, and we are able to also actually understand which one is at a high risk of either us losing the mother and maybe losing also the baby at the same time. So what could be the risk factors for placenta previa? So when you look at the risk factors for placenta previa, it's more common in women who are aged 35 and above years. Then also increasing parity and multiple gestations. Women who have delivered very many babies, they are at risk because the placenta has to look for a site whereby it doesn't get where there was a previous placenta. So in case the mother can deliver very many babies and they are occupied at the upper segment, this placenta will try to look for where to embed and may end up at the lower segment of the placenta and of the uterus, and the mother can easily end up with placenta previa. So increasing quality and multiple stations can also be a risk factor for placenta previa. Then uterine scarring. Uterine scarring, as I've explained already, are most commonly due to prior cesarean section and curettage. Curettage, this one can be done if a mother has had an abortion. They are removing the remaining products of pregnancy. They do curate, but it can end up actually injuring the inner layers of the uterus, the endometrium, and ends up with scars. And when it ends up with a scar, the placenta cannot embed where there is a scar, and it will end up looking for a new site whereby it can be able to embed and get good and enough nutrients for the baby. And for that reason, it may end up embedding at the lower segment of the uterus, causing placenta previa. Then infertility treatments sometimes can also predispose our mothers to placenta previa. Then prior placenta previa, as having mentioned, that gives a 5% chance of these mothers again getting placenta previa conditions in pregnancy. Then previous history of placenta previa, which is the same as that above, as prior placenta previa, is the same as previous history of placenta previa. That's why it's always very important for us to ask these mothers when they come to get a comprehensive history to understand the prior histories, the prior emerging conditions, the prior complications that they went through during the time of their previous pregnancies. Then mothers who are smoking. And mothers who smoke cigarettes, they are also at a high risk of getting placenta previa because it causes constriction of the blood vessels and reduces supply of nutrients and blood to those areas. And it ends up becoming something like previous scars and so forth, causing the placenta to look for a better place to embed, causing placenta previa kind of condition. So, what could be the differential diagnosis? Besides placenta previa, we also get to know that there are some other conditions that can also present just like placenta previa. And sometimes we can misdiagnose our mothers like they have placenta previa and it is actually different condition. So I think it is also very important for us to know what are those conditions that can actually present same way like placenta previa. So the differential diagnosis for this case are abruptio placentae and then vasa previa, cervical polyps, and cervical cancers. As you already mentioned above, are some of the causes of bleeding uh, in the genital tract before delivery. Then what could be the signs and symptoms of placenta previa? So when a mother comes to you, you can use different signs and symptoms for you to actually know and understand or diagnose your mother as having placenta. One of the signs and symptoms is painless vaginal bleeding, typically starting at rest or during sleep. So these mothers pain during the time when they are bleeding, they just experience blood, experience that there is something happening and may not feel any pain at all. Sometimes even they just wake up and sleep and realize they're in blood. And that can be one of the signs of placenta previa and usually begins around the 32nd week of gestation due to Braxton Hicks contractions. And the Braxton Hicks contractions are basically contractions that start at a time when the uterus is actually preparing for labor. And you may think the mother is in labor, but actually the uterus is just exercising and preparing itself for that time of labor. So around that time, these mothers can experience bleeding, and if the placenta is located at the lower segment of the uterus, it can cause bleeding, and that can be one of the signs and symptoms of a placenta previa. Then the fetal head remains high. You realize the head of the baby remains high, leading to presentation and unstable lie. And before this, I think the previous slides up, we had rich presentation and realized placenta was actually embedded at the lower segment of the uterus. So when the placenta is located at the lower segment of the uterus, it also hinders the head of the baby, the presenting part, from being located at the normal position, and also the life of the baby can be interfered because there's a little room at the lower segment of the uterus, and the baby tend to lie instead of putting the head down. And the baby tends to put the head up and the buttocks down, making which is not obstructing down. The placenta is obstructing down, whereby the head cannot engage, the head cannot descend, and also it can affect labor and can affect engagement of the presenting part. So that leads to malpresentation and unstable lie of the baby. Then there is severe bleeding, which may result in low blood pressure, high pulse and respiration rates, and then also shock. So when these mothers actually start bleeding, it's not something simple, especially when it is a grade 3 and grade 4. They can end up with profuse severe bleeding. Some mothers come when they have low blood pressures. Some of them end up with in shock. And we all know when someone loses blood, we end up having a patient with shock and the blood pressures go very low. The blood pressure is going very low. We end up having high pulse because the heart can't compensate. So the compensatory mechanism in the respiratory system ends up shooting up the pulse because the blood pressures are low to compensate the supply of oxygen in the blood to the vital organs in the body. So even the respiratory rates can become high because the person is trying to take in more oxygen because there is decreased levels of oxygen in the blood. because she has lost a lot of blood that provided her enough oxygen. So the respiratory rate gets high, and the mother can easily present to us when she is in shock. And all the signs and symptoms of shock, the cold, clammy skin, suffocation, low pressure, and unstable she can display pictures and all that. So severe bleeding is actually very dangerous during the time of mothers in the placenta preview. So, what could be the investigations? The investigations that can help us, besides the signs and symptoms, for us to really understand and take this mother as having placenta previa, we need to do ultrasound scan, which can help us to localize the placenta fetal well-being. And then we can also do blood for CBC, and then HB and the platelet counts. So when these mothers come in, very important for us to know the CBC, and the CBC can give us the HB estimation, hemoglobin level estimation. It can tell us the platelet counts, and this can help and guide us in the intervention of these patients. Then blood grouping and cross matching has to be done, and because the mother has lost a lot of blood, we need to transfuse this mother, and of course you very well know you cannot start transfusing some not blood group, and even if you blood group when you go the mother's blood plus transfuse. So these investigations are very vital and very key for this. So we need to do these labs investigations to and guide us in the management of this. So we want to look at the behavior. How do we manage this as get it? So management depends on factors such as um, and fetal conditions, placental location, and patient. So the blood loss, it depends on how much this mother has lost, and then and fetal conditions. How is the mother herself? Has fetal blood? How is she? And how is the baby? Is the baby distressed? Because by losing a lot of blood from the mother, even the baby's condition, I believe, and we very well know, will be affected. So placenta location matters in the management because we have already talked about the four different types. We have the normal location of the placenta. We have the one that is at the lower segment, which is not matching the edge of the cervix. Then we have the one that is actually covers the cervix, but that is when the os is closed. But also when it dilates, it can move and does not cover the whole cervical os. Then the fourth one covers the whole cervical os. Even when the cervix dilates, it still covers the os, and it is called the severe grade, which is grade 4. So we need to know the location of the placenta in our management. Then we also need to know the gestation age. So the gestation age of the baby can help us in the intervention, either to deliver this mother immediately, or we can do conservative management depending on the maternal and the fetal conditions. So if you're in the hospital and you cannot manage this mother, or you are in the health center and you cannot manage this mother, you refer all pregnant women with vaginal bleeding to the hospital or to a CMOC facility. So a CMOC facility basically is a comprehensive emergency obstetric care facilities. So if you cannot handle them in the BMOC facility, then you refer them to the CMOC facility where you find a theater, you have the doctors, and then you can blood transfuse this mother, and the baby and the mother are actually saved. And that is where we get the CMOC care that we can be able to give to this mother. So CMOC in full is comprehensive emergency obstetric care uh, facility, and it's like from health center for hospitals, referral and rural hospitals, and then we have the national hospitals where we can get all the services to take care of these emergency obstetric conditions. Then we have the BMOC facilities, BMOC basic emergency obstetric care, whereby we provide what we can so that we can handle the emergency maybe the cesarean sections, and that can be in a health center too. So when these mothers come to you, do not handle these mothers. Basically refer them to the BIMOC and the CMOC facilities. Do not handle these mothers from the BIMOC facilities because you may endanger the life of both the mother and the baby. So as soon as they reach your facility and you see the mother is bleeding, can't do the investigations from our health center 3. You can't do investigations from our health center 2. So you refer this mother immediately to a CMOC facility. Then intravenous drip of saline lactate should be initiated before transferring these mothers. So immediately before you send her off from your facility, make sure that you introduce intravenous line and put fluids to help this mother and the baby. She's losing blood. She is actually now having low supply to the baby. Even her herself, she's losing blood and she's having no supply to the vital organs. But when you give her these fluids will help to regulate the amount of blood in her body and help to supply the vital organs, help to supply also the baby, and this mother can be resuscitated until she reaches to the CMOC facility. So the aim is just to control hemorrhage and conserve the pregnancy up to 38 weeks of gestation. But if you cannot control hemorrhage, then this mother has to be delivered immediately. Blood test for hemoglobin, and cross-matching has to be done. That is in the general management. Then avoid abdominal palpation to prevent severe bleeding. If this mother is bleeding, then you should also avoid palpating this abdomen because you might be causing more harm to the baby and the mother, and you might be increasing also more bleeding. Then monitor and save all pads to assess blood loss. This is where we have a challenge. In most cases, we have always failed to assess the actual amount of blood loss that these mothers lose, and we end up either underestimating or overestimating. So we need to understand how we are able to estimate this blood loss so that we can know how much the mother has actually lost so that we can be able to intervene appropriately. So we need to save some of the pads. And in most cases, our mothers don't use pads. Some of them come from rural areas and they're just using either a cloth, and it becomes very difficult for us to actually estimate. But it's very important for you to save all the parts that the mother has been using so that you can be able to estimate the amount of blood this mother is losing. Then provide a high protein diet for this mother so that it can help her in recovery. Now, after you've managed the bleeding, you've managed to the mother and the baby, you can intervene in the high protein diet in order to help this mother recover. You know what protein does. It helps to actually rebuild, it helps to in the healing process and all that. Treatment managing placenta previa. I want us to do this in relation to the weeks of gestation. So when a mother comes to you, has placenta previa, and her gestational age is 26 to 37 weeks, and she has no bleeding, as are there. They are not bleeding, but when you scan, actually she has placenta previa. So the diagnosis is usually made through incidental ultrasound scan, and that's why we encourage our mothers to always do ultrasound. So when our mothers come to antenatal, let's always encourage them to have an ultrasound scan at the early age of their pregnancies and also at the later age of their pregnancies. And we are looking at 26 to 37 weeks. And when it's 37 weeks, that is term pregnancy. It is pregnancy, the mother can be delivered, and this baby is a very mature baby at 37 weeks. So you can get another scan, and you've done an ultrasound scan and it is showing placenta previa, but the mother is not bleeding. So what do? You cancel and avoid strain of fertility, including sexual contact. So when you get this mother, then ultrasound scan, and the ultrasound scan indicating that the mother has placenta previa and the weeks of gestation are 26, between 26 and 37 weeks, and she's not bleeding. You can also this mother explain to her the effects about yeah, tell her the actual condition, outcomes, and all that, and tell her what she can do to avoid bleeding. So you have to educate this mother and tell her to avoid strenuous work like lifting of things, heavy things, overbending, and also sexual activities. The mother can try to at least stop for some period so that this baby can grow without her getting a problem. So you can also give corticosteroids less than 34 weeks of amenorrhea in case you see this mother is at risk of starting over to bleed and you feel like you should deliver this baby, though the mother is not bleeding, but you see other risks that danger, then you have to deliver food. So you have to give her at least corticosteroids day if it is below 34 weeks of amenorrhea. And we give dexamethasone IM 6 milligrams every 12 hours for 24 hours. That is one day. And helps babies their lungs and they mature even when they deliver them at that time. It helps to make this baby actually manage its breathing because the lungs are being supported. So IM methadone is very important for these babies, especially those below 34 weeks of malaria. So we need to give them before the babies are delivered and should take at least 24 hours and should be given 2 doses after every 12 hours before the delivery of the baby. Um, you continue with the hematinics and this folic acid, ferrous sulfate, and when we give them, it helps to boost the formation of the red blood cells because they have lost blood. So it helps to boost, or else they have not yet bled, but can help to boost. Because we very well know if these mothers come and they already anemic, so they have little blood, then again they bleed. It causes more the mother and the baby than these ones who have enough blood or whose hemoglobin levels high than those whose hemoglobin levels are very low. So if not yet a facility or blood referred to the same facility. As earlier on I mentioned, it is not able to handle this mother in the facility. If it is a remote facility whereby you're only providing basic care, refer this mother to the senior facility, the comprehensive emergency obstetric and newborn care. So that is in the health center 4. So in health center 3, please refer these mothers to a health center 4. So if a mother is stable and the fetus is alive, conservative management is of gestation. So we should not hurry to deliver these babies if the mother is stable. So we can keep these mothers until the baby is 37 weeks of gestation so that we don't also put our babies at risk of dying due to prematurity because we realize most of the babies die due to prematurity. So the mother is stable, give conservative management, keep monitoring, give a close monitoring to these mothers till it is 37 weeks gestation. So discuss on birth preparedness and complication readiness. So you have to discuss with and the family. So please advocate for husbands to always escort their mothers or their women for antenatal. So when they come to antenatal and they are able to the certificate, you can be able to explain to them, tell them the risks of condition, help them in birth preparedness, because the type of the complication or the type of the grade, the placenta previa can be able to tell us how this mother is going to be treated and what complications can occur so that the family can be prepared of any kind of delivery and also the complications that can easily occur. Then also counsel to continue with the ANC and report hospital if bleeding starts. So you have to cancel. When you cancel, you tell her to continue with her ANC, and as she continues with her ANC, also tell her that there is need for her to come for the hospital in case she starts bleeding. So some mothers they will tell you, I was told to go back last week, but I could not go because I had this problem. And she may end up with a problem by the time she comes. She's already having a serious complication. So we really have to take support to advocate for birth preparedness and readiness for complications uh, for our mothers so that we can be able to handle this. They are prepared psychologically, they are prepared as a family, prepared as a to handle whatever comes her way. But when you don't explain to them, it becomes a challenge at that time when they come, and it ends up giving us more issues on how to handle them. So also hospitals if bleeding is revealed. So in case there is bleeding, that's when you cancel this to report to the hospital in case bleeding starts. But in case the mother is bleeding, we need to hospitalize this mother. We need to admit them and they stay in the hospital so that we can monitor the bleeding and also we can be able to intervene and save both the mother and the baby. We can decide if the mother is bleeding profusely or severely. We can be able to do an emergency delivery and we can be able to save both the baby and the mother. So you need to perform repeat ultrasound scan at 32 and 36 weeks. So we may do a scan at the earlier age of the pregnancy, the earlier weeks, and it may show us that there is placenta previa. But as the pregnancy continues to the latest weeks, for example, 32 and 36, we may repeat the ultrasound scan and it may not actually reveal the placenta previa. That's why it is very important. If a mother did a scan in the early weeks of gestation, we should also repeat around this period of 32 and 36 weeks when the pregnancy has grown, when the baby has grown, so that we can be able to actually confirm the diagnosis that this is placenta previa. So, in management at gestational age of 26 to 37 weeks with mild bleeding, the first one, we're managing the mother and there was no bleeding. But here now we are looking at a mother at 36 to 37 weeks, but there is mild bleeding. So mild bleeding in placenta previa is where there is no decompensation or deranged a kind of vital signs or immediate danger to the mother and the fetus. So the bleeding is mild, and when the bleeding is mild, you realize that the mother is not actually having a low BPs, she's not having high pulse, she's not in shock, and the baby is also actually having good fetal heart rate. But when the mother is having profuse bleeding, you realize that all this I've mentioned deviates from normal to abnormal. But in mild bleeding, there is no decompensation of all these other vitals, and they are all normal because the bleeding is not much. So, we also have to discuss with the mother and family on birth preparedness and complication readiness. Besides the other where there was no bleeding, even here when there is mild bleeding, we still have to discuss about the birth preparedness and then the complication readiness because we realize placenta previa causes a lot of complications, both the baby and the mother, and we end up losing either the baby or both of them. So we need to talk to the mother, we need to talk to the family, tell them about the kind of possible ways of delivering, and also we need to tell them the possible complications so that they can be ready to handle the complications together with you, the health worker. So admit or refer to a functional CMOC facility till the baby is stable and healthy. And if the mother care, refer this mother to a comprehensive emergency obstetric care facility where they can be able to provide that kind of emergency interventions. So you refer this mother and she's admitted in a small facility until she delivers. So avoid strenuous activity, including sexual coitus that results into orgasm. So we all very well know strenuous activities, even sexual kind of activity can cause a lot of pressure onto the abdomen, and then it can cause an effect onto the placenta and cause placental separation, and by that it can lead to placenta actually detaching, or it can cause severe bleeding to both the baby and the mother. So mild bleeding should not be taken like it is something that is simple, but we need to advise them, we need to counsel them, we need to tell them the effects so that they can avoid all these kind of activities, especially when the pregnancies are still very small, when the gestational age is maybe below 34 weeks, then we are not actually going to see that to deliver this baby immediately. If it is mild bleeding, we just cancel them, try to do some conservative management until this baby may mature. If the bleeding still actually doesn't increase severely, or even it may end up stopping, and these babies may increase their weeks, and we deliver a baby that is able to survive. So besides giving the advice and the counseling on strenuous activities, we also realize that we give corticosteroids, and that is if the pregnancy is less than 34 weeks of amenorrhea, we give IM dexamethasone 6 milligrams every 12 hours for 24 hours. 24 hours we very know is 1 day. So 12 hours for 1 day. And we have to make sure that we really give these doses because it helps in the lungs. It helps these babies that when they deliver them below 34 weeks, they can easily survive. They're able to support their breathing because of the impact and the action of dexamethasone onto the lungs. The responsive mothers should receive anti-D immunoglobulin, and they give them 300 milligrams at 28 weeks, and again at about or during 34th weeks, and some can be given 72 hours after delivery. That is now if the mother was not identified during this period of 28 weeks and then 34 weeks, because if the mother is rhesus negative and she delivers the first baby, that baby may survive. But if the mother has pregnancies, they end up actually being taken as a foreign body by the mother's antibodies, and the babies always are lost as abortions. So we always support these mothers by giving them the anti-D immunoglobulin at 28 weeks and at 34 weeks. And those that we don't identify around this period of weeks, we give them at 72 hours after delivery so that they can continue having the next pregnancies successfully. So continue with the routine or daily monitoring of fetal well-being and hematinics. So we give these mothers these drugs to help boost their hemoglobin levels. And then also we have to continue monitoring the fetal hearts of these babies, because when the mothers lose blood, it also affects this fetus inside the uterus. So we have to continue monitoring the fetal heart. We have to continue monitoring the bleeding. We have to boost the formation of the red blood cells so that the circulatory system continues being normal, so that the baby receives what is expected, the nutrients, the oxygen, for it to grow and actually mature. If we are doing the conservative management, and also the mother herself needs to have enough blood, which will help her carry the pregnancy until she delivers, normally. So if a mother is stable, no active bleeding, and fetus is alive, then you continue till 37 weeks of gestation. So the mother can come when she is not bleeding, but you've done a scan and you've identified she has glaucoma. If the mother comes and she has mild vaginal bleeding, try to give her a bed rest, cancel them on strenuous activities, including sexual activities, and then try to make sure that this mother is provided with dexamethasone, she's having enough bed rest, and if the bleeding stops, try to make sure that this pregnancy ends at least up to 37 weeks before it's delivered. If minor placenta previa like type 1 and 2A induced labor. So if no contraindications to vaginal delivery, that is type 1, so the anterior is the one that is up and the posterior is the one that is down. So when you look at the type 2A, that placenta is actually seen at the anterior part of the uterus. Then type 2B is at the posterior part of the uterus. So there are different indications for delivery, whereby when you look at these grades, the grade 2 posterior placenta is when the placenta is on the lower side of the uterus. So it's at the lower part of the uterus, and it can also be some kind of a complicated location, the placenta previa, whereby we do not put this mother at a risk to deliver vaginally. Then the anterior placenta, the one that is grade 2, it's not typically for a concern, I can say, because the mother can easily deliver vaginally. So that is what this statement is telling us. If minor placenta previa, like type 1 and 2A, induce labor. So you can induce labor and this mother can deliver vaginally. But when it is type 2B, then this mother cannot deliver vaginally. So if degree of placenta previa is type 2B and if major, then deliver by cesarean section. So this grade 2 has two different subtypes, which is type 2A and type 2B. So the type 2A is the one which is posterior, and that one you cannot, type 2B, you cannot risk the mother to deliver vaginally, but the one which is type 2A, that one is anteriorly and the mother can easily deliver vaginally. For immediate delivery by C-section. So where do you say that this mother should be delivered immediately by C-section? One of them is when there is active bleeding. Delivered immediately by cesarean section. Then the other one is gestational age. If the gestational age is more than 37 or it's 30, has been having different conditions. The baby was not getting enough nutrients. Either the placenta was not able to provide enough nutrients to the baby because it was located at the lower segment, and at the lower segment there is little kind of blood supply, and there was little nutrient that was getting to the baby. So this baby was actually not growing well. So the baby can easily even die. So with this evidence of IUGR, this baby can easily be delivered very fast because the mother can bleed, and uh, low birth weight for age, so that it cannot we cannot lose it, and this can be done by immediate cesarean section. Then non-reassurance fetal status. The non-reassurance fetal status is when you're monitoring the fetal heartbeat, and it's actually not giving you the normal ranges. And we all know the normal fetal heartbeat to 160, and above 160, then that one is already an indication of kind of baby getting either asphyxiated, and we may have to intervene. Instead of us waiting for this mother either to labor and yet she's either bleeding, the baby is dying, we have to do immediate delivery by cesarean section, and hereby we are saving the baby and also the mother. Then IUFDs. The IUFD, intrauterine fetal death. Most of our mothers because the cervix is covered by the placenta, the baby cannot pass anywhere, the baby has already died. So you cannot say that you're going to deliver this mother vaginally. You cannot. The baby is dead, the placenta has covered the os. This baby cannot pass anywhere. So the only way of delivering this mother, so that she may not lose again a lot of blood, whereby we may end up losing both the baby and the mother, then we have to do an immediate delivery by cesarean section to deliver this baby, so that we can now save the mother because we have already lost the baby. So sometimes people think that the baby has died, so let's leave the mother to labor. But there is nowhere the baby can pass because the cervix is closed with the placenta, and as we keep waiting, the mother is bleeding, and we may end up losing both of the two people. And then also we need to note that placenta previa is associated with morbidity, adherent placenta. Uh, so adequate preparation and expertise are a prerequisite. Consent the mother for possible hysterectomy. So in most cases, some of these placentas end up adhering, they fail to be delivered, and for that case they can only uh, remove it by hysterectomy, and the mother ends up losing the entire uterus. So you have to tell these mothers these possibilities, and that's why we were saying that you have to tell them the possible complications so that they can be ready to actually handle them. So we have to consent this mother, tell them the possible outcomes, those complications that can occur even when they are taken to theatre. Because many times people think going to theatre is just going, they cut you and you come out. No, even theatre has its own complications of anesthesia. It has its own complications of a difficult operation that may lead to even loss of lives, both the baby and the mother. So we really need to counsel these people and tell them the possible outcomes in relation to their conditions so that they can be able to prepare for any possible outcome during that process of management. So we also need to counsel our mothers. There are sometimes women who say they don't want to deliver vaginally, they want to be operated when there is no indication for a Caesar. It's not actually right because a Caesar is not the final solution. The mother has no indication for being operated, please let's make sure that you monitor this mother closely. Let's do examinations for case of placenta previa, as you have mentioned, if it is not type 1 or type 2 or type 2 or grade, they grade them or they say the types. So if it is not type grade 2 posterior, then these mothers can deliver normally. But if it is grade 1 and grade 2 anteriorly, then these mothers can deliver vaginally, unless there is any other contraindication to vaginal delivery, then these mothers can be operated. Or else, if it is type 3 and type 4, then they can be delivered by C-section. Measures taken in placenta previa cases. What are the measures that we really need to take and we need to put into consideration when we are handling these mothers with placenta previa? So frequent vital sign monitoring is very key. Having mentioned already about decreased blood pressures, increased pulse, and also signs of shock. This can help us to identify very early the complications or the early signs of shock before these mothers get into shock. Because when they get into shock, we end up even failing to manage them and to save them. So frequent vital sign monitoring is very key when you are handling the mothers with placenta previa. Then speculum examination on the third day to exclude incidental hemorrhage. So if a mother is not bleeding, please do not do a vaginal digital exam, because when you push in your fingers, you're going to irritate that placenta and it is going to start bleeding. So we are advised never to do digital examination on mothers with placenta previa. So we need to do a speculum exam just to inspect and see what is there, whether the os is dilating, whether the cervix is out of the os when it is dilating, or it has covered the os, or it has not completely dilated, so we can be able to see how to intervene and manage this mother. Then scanning at 34 weeks to assess progress and confirm the diagnosis. So if you did a scan, or if these mothers did a scan before 34 weeks of gestation, it's also advisable that when they reach 34 weeks of gestation, they should also do a scan that can help us confirm the diagnosis of placenta previa. Then patient retention in the hospital until 37th week for examination under anesthesia. So we are supposed to retain these mothers. We are not supposed to allow them go home if we are seeing that there's a possibility of this mother not complying with the advice we are giving them about strenuous work and so forth. Let's keep these mothers with us and make sure that we do examinations before they go, and then prepare them for cesarean section in case there is any severe bleeding, and that's when we shall be able to save them. Avoid even the baby has no fetal heart, and we end up having a lot of challenges in managing both the baby and the mother. So EUA is basically examination under anesthesia, whereby we give some anesthesia to these mothers so that when we're examining them, they don't feel the pain, and you're able to actually see what you really need to see and be able to diagnose rightly and be able to get what you needed to get and assess. And this can help you in the management of these mothers. Previous slides, in type 1 and 2 with an anterior placenta, rupture of membranes and spontaneous delivery may be considered. So if you have type 1 and type 2, and type 1 and type 2 have different subtypes, which is anterior and posterior. So the anterior, there is a possibility of vaginal delivery. So when you realize that this mother has type 1 and 2, which is anterior, you can rupture the membranes and then spontaneous delivery can be considered. Looking at Bishop's score of 8 and above, but below 6 is unfavorable for induction. So sometimes we can do induction, but we have to look at the Bishop's score. And when you look at the Bishop's score, there are different parameters that we observe. And when we score and we get 8 and above, then we can be really sure that when we do induction of labor, we can be able to succeed in delivering these mothers. But when it is below 6, then your induction may fail. So we have to look at the Bishop's score so that we can be able to achieve spontaneous vaginal delivery. So labor induction with oxytocin drug can also be done. Having already talked about the Bishop's score, you can only do it the induction with oxytocin when your score is 8, but below 8, around 6, you may not be able to succeed in your induction. So in type 2, with a posterior situated placenta, and type 3 and 4, C-section is performed. So you should not risk the mother when you realize that it's type 2 but is a posterior one. Posterior meaning it is down the lower part of the uterus. Do not risk this mother to have a spontaneous vaginal delivery. Let this mother be delivered by C-section together with the type 3 and type 4 placenta previa. So what can be the complications? Having talked about placenta previa being an emergency obstetric condition that has affected our babies and our mothers, we also have also its complications and so we have postpartum hemorrhage, always in APH. Antepartum hemorrhage. Antepartum is before delivery of the baby, and postpartum is after delivery of the baby. So when you're encountered with a mother and she's bleeding before birth, then you should also take keen note on this mother that even after delivery, she may end up bleeding, and that is what we call postpartum hemorrhage. Then fetal hypoxia. Fetal hypoxia can be caused due to placenta previa because the mother has bled and there is little circulation of blood to the fetus. The baby ends up having hypoxia, and this can cause damage to the brain of these babies, and they end up with cerebral palsy because the brain cannot coordinate the activities of the body. So it's very important to handle this during that time, that the baby should not get into hypoxia because it can affect the brain of these babies. Then also we can have peperiosepsis. These mothers can end up with peperiosepsis. Peperiosepsis occurs during the period of purpurium. And during this period, these mothers need actually to have a good diet. That's why we say they should feed on a lot of proteins which help in repairing of the tissues because these mothers have lost a lot of blood. And I want to say that when the mother has lost a lot of blood, there have been little kind of a provision or perfusion on the tissues, and this can end up also having low provision or supply of nutrients to those areas and can delay healing, and they can end up even with this peperiosepsis. So peperiosepsis, when you look at it, it's more of low provision or supply of nutrients to those areas because there is little blood in the body. The mother is already anemic, and anemia because of the placenta previa can be the major cause of this peperiosepsis. So anemia comes in as one of the first kind of factors or complications. After the mother has lost blood, what happens? She becomes anemic, and that one can cause fetal hypoxia. Then later comes into peperiosepsis, but immediately after delivery, we end up with postpartum hemorrhage. So here is the one that I really don't like to talk about: maternal and fetal death. Losing a mother and losing a baby is very painful, but placenta previa, if not well managed and well handled in losing these babies, which is something very bad. And I think it's something which is serious in all our countries. Here in Uganda, when a mother dies or a baby dies, you're supposed to give a report on what could have happened, and people have to see there's what we call maternal and perinatal death reviews, and we have to review this mother from the time she started antenatal, from the time she came when she was in labor, from the time she delivered, what could have happened if she delivered until this mother died. And in maternal death review, we are able to identify the gaps, what we did not do well, what we did well, and if we did do well in certain areas, what do we need to do so that we cannot lose these mothers again if you're encountered with such a case. So maternal and fetal death is something which is so painful for the government, so fetal death, which is very bad. So we said earlier on that placenta previa and placenta abruptio are the major conditions in APH, antepartum hemorrhage. So antepartum hemorrhage handles majorly these two conditions, placenta previa and abruptio placentae or placenta abruptio. So having finished to talk about placenta previa, we have discussed about placenta previa, what placenta previa is, the different types of placenta previa, how to manage placenta previa when the mother is not bleeding, when the mother is having mild bleeding, and when the mother is having severe bleeding, and then its complications. So I want us also to look at abruptio placenta or abruptio placentae. Sometimes some people call it placenta abruptio. So what is it all about? So abruptio placentae is bleeding resulting from the premature separation of a normally situated placenta occurring after the 26th week of gestation, or it refers to bleeding into the genital tract after after 26 weeks of gestation and before delivery in a normally situated placenta, and fundus in brackets. So fundus in brackets means the upper part of the uterine segment. So the fundus is that top part of the uterus. Then down is the lower segment. So when the placenta is located at the fundus, that is the upper part of the uterus, it is normally situated. But previously we talked about placenta previa. That is when the placenta is located at the lower part of the uterus, which is the the lower segment of the uterus. So I want to say that when placenta abruptio occurs, it doesn't mean the placenta is located down, no. This placenta can be located at the normal part of the uterus, at the fundus, at the upper part, at the upper segment. But what happens is it separates before the baby is born. And we very well know the placenta has to separate after the baby is born. But when this placenta separates before the baby is born, that is abruptio placentae. So its associated conditions include physical conditions, hyperity, trauma, polyhydramnios, high fevers, and external factors like sudden shock. So some of our mothers end up with premature separation of the placenta before delivery of the baby because either they have hypertension, and this because of the high pressures they end up separating this placenta. Because of the hyperities, they end up separating this placenta. Because of trauma, some of our mothers end up falling or they have a kick by their partners, they get accidents, and the placenta separates before the baby is born. So that one is called abruptio placentae, which is antepartum hemorrhage, bleeding before baby is born. So what are the types of abruptio placentae? So the different types of abruptio placentae, three clinical presentations of abruptio placentae. They have three clinical presentations, and that's how they are classified or typed. So one of them is mixed, and the mixed one is where there is bleeding. Both the bleeding is revealed or concealed and concealed. You realize the mother has signs of bleeding per vagina, but also when you examine the mother, there are signs of some blood being retained inside the uterus. So that is the mixed kind of abruptio placentae, where there is bleeding. Both there is that is revealed, you see the blood, but also there's some blood remaining inside the uterus. Then concealed. Concealed blood is trapped between the placenta, membranes, and the uterine wall. So there is no visible bleeding. You don't see the bleeding per vagina. When you examine this mother, there is no blood seen around the vagina. There is nothing completely, but the placenta has separated and has decided to conceal the blood inside within the membranes and the uterine walls. But when you do a scan and when you examine this mother, you realize there's something that is inside, some fluid, and that is actually blood. Then the revealed one, it is a free vaginal hemorrhage or visible. So you realize the mother is actually bleeding, and when you examine her, there is oozing of blood around the vaginal os. And that one is the revealed type of abruptio placentae. So there are three mixed abruptio placentae where the bleeding is both revealed and concealed. Then there is concealed where the blood is trapped between the placenta, membranes, and the uterine walls, and there is no visible bleeding when you examine the mother. Then the other one, the revealed one, is where there is vaginal hemorrhage. You will see the blood flowing from the mother's vagina. So what could be the causes and predisposing factors to placenta abruption? So in everything or in every condition, there should be causes or predisposing factors. So for the case of placenta abruption, we realize that some of the causes can be previous history of abruptio placenta, and we also said in the placenta previa, the previous history can be also one of the predisposing factors. Then there is direct trauma to the abdomen or accidents. It can be domestic violence from their partners. It can be due to either road traffic accidents or just a fall on her abdomen. Then she ends up actually causing that separation to the placenta prematurely. Then hypertensive disorders of pregnancy can also cause that separation of the placenta. Then polyhydramnios, when there is increased fluid in the abdomen, it can also predispose to the separation. When the membranes rupture before the baby coming out, that force of that water coming out can also suck the placenta when it is located at the fundus and can easily separate due to the force and the pressure. Then external cephalic version, and this one was actually long time ago done by the traditional birth attendants trying to turn the babies, especially when we have babies that are lying abnormally, malpresentations and lies. These mothers, these traditional birth attendants try to turn the baby to lie normally, and they end up actually detaching the placenta. But right now, it's not advisable because you end up causing complications to the baby and the mother. I want to give an example of a mother that we had. This was a well-educated mother, and she was received by her friends to go and turn the baby because they did a scan, and after doing the scan, the baby was actually a breech. Instead of presenting with the head, the baby was presenting with the buttocks. So as she told the friends that I've done a scan and this is what the scan has revealed, they advised her to go to a TBA who tried to turn the baby, but instead the placenta separated and she started bleeding When she reached the hospital, there was no fetal heart, and her condition was deteriorating. She was almost getting hemorrhagic shock, and the only option was to hurry to take her in. They did a C-section, delivered the baby, and actually the main intention was to save her, and she lost the baby. I interacted with her because I didn't know the whole story. I interacted with her, trying to sympathize with her about the loss of the baby, and openly she told me, so for us in Uganda, anyone who is a health worker is called Musao, and that is the Luganda language. So she said, I did this and this, and I cannot forgive myself. So sometimes when you do these scans and we realize that there are some abnormalities on our babies, especially abnormal eye and then malpresentations. Let's counsel our mothers. Let's not just give them the scan results and tell them your baby is not lying well, your baby is lying like this and that. But let's tell them also the consequences, the complications that can occur. And if at all this mother was told all this, I think should have not attempted to have gone to a TBA who messed up with her baby and almost lost her life. So all the results we get during the investigations, labs, let's try to see how we package the information to our clients, how we package the information to our mothers and the family members so that they can understand the possible outcomes, both the negative and the positive. Then another one is the short cord and then choriamnitis. If there is a short cord and choriamnitis, can also cause placenta abruptio. If the cord is short, as the baby is trying to maneuver, the baby can easily pull the cord, I mean the placenta, and can easily separate. Then choriamnitis, this is an infection that can occur around the chorion and the amnion, and it can affect the placenta and cause a premature separation of the placenta due to the infection. Then uncontrolled artificial rupture of membranes. When you're rupturing membranes, as having mentioned about polyhydramnios, we need to make sure that there is no high force that comes with the flow of the liquor, because it can easily enter and can easily separate. So when you're doing artificial rupture of membranes, you're supposed to do it controlledly, whereby you're supposed to there is a hook, amniotic hook, that you're supposed to use for rupturing these membranes, because it has to give a slow flow of amniotic fluid, not abrupt kind of sudden pouring of the fluid, because it can give that kind of pressure and force, and then it can pull down the placenta. Then folate deficiency, we talked about folic acid and so forth, and we talked about giving these mothers. This can also cause, and smoking. Mothers are advised not to smoke during pregnancy because it can cause an issue to them. And this one is external cephalic version, which I already mentioned, and I think it has repeated here, but it's the same point. What could be the differential diagnosis of abruptio placentae? Because you can get these mothers and they come bleeding, and you will think it is abruptio placenta, and yet it's not. So some of the possible differential diagnosis can be placenta previa, which we have already talked about, and can be placenta abruptio, and can be uterine rupture. When the uterus has ruptured, the mother can also bleed, also cause bleeding and abdomen. And the bleeding may come from any site of the abdomen if there is trauma, and yet it's not actually directly onto the placenta. But you may think it's a placenta abruptio, and yet it's not. Then degenerating fibroids. Degenerating fibroids can also cause bleeding. Their mothers, many times we have done C-sections and we have realized the mother is actually having a very big fibroid, but also she's pregnant. So when they are degenerating, they can easily cause some bleeding, and you may think it is abruption, and yet it's not. Then severe cystitis. So there can be a cyst within either the os, and it can cause some bleeding, and you may think it is abruption, and yet it is a severe cystitis within the cyst that could be around the vaginal orifice or around the cervical os. Then pyelonephritis can also be one of them. Ovarian cyst torsions, bleeding ectopion. Those are products of conception which results from an ectopic pregnancy. And also we can have cervical polyps or malignancies. And the other time we talked about cervical cancers, and they can also be bleeding, and you may think it's from inside and it is within the cervix. What could be the signs and symptoms of abruptio placenta, so that we can be able to tell that this is abruptio placentae? One, revealed type. As mentioned about the types, the revealed type is the one that you see the blood flowing from the vagina. So vaginal bleeding, possibly there can be abdominal pain, there can be raised pulse, and then low blood pressure or hypertension. Hypotension, actually, it is not hypertension, but is hypotension. So the low blood pressure or hypotension. Hypotension is when the blood pressure is low. So that is in the revealed type of vaginal bleeding. So when you see the blood out, that is the revealed type. So you can only say that this is abruptio placentae, the revealed type, when you see the blood. And when you see it, when you examine the mother, the abdomen can be painful because of the separation of the placenta, and then also her pulse can be high because she has lost a lot of blood, and also her blood pressure can be low, and that is hypotension. Then concealed type. The concealed type is where we don't see the blood. So severe abdominal pain. You realize that the mother has severe abdominal pain, and the mother can be in shock, but you don't see any blood. Kumbe it is concealed. Then also there is no vaginal bleeding, tender and board-like uterus, absence of fetal parts and heart sounds. You may not get the fetal sounds, and you may not get even the heart sounds of the baby. When you look at during the time when you're monitoring the fetal well-being, you may not get all that, and you may realize that this baby might have either passed on, or the baby is having asphyxia, and you may end up losing this baby if there is no appropriate and fast intervention. So there will be severe abdominal bleeding because the blood has concealed, and the mother can be in shock because there can be too much blood inside. She has lost a lot, though you don't see it per vagina, but the mother can get into shock. Then combined type, the features of both revealed and concealed bleeding can be seen. So higher degree of shock than visible blood loss. Then you can see the mother is actually in shock. But when you look at the blood is minimal. And yet there is a lot of blood also concealed inside. So there can be tender and rigid uterus because the blood is concealed inside. So the uterus can be rigid, it can be tender and so painful, and she can be having constant pain. When you try to tell her to turn, she cannot. When you try to touch, she's feeling a lot of pain. So those can be the signs of a combined type. And also when you examine her, you see some bleeding per vagina. What kind of investigations are you going to do for this mother? So blood grouping and cross-matching, and then you book blood products, preferably packed red blood cells or whole blood, and platelets is preferred. So investigations are done. I think most of the investigations are shared both in placenta previa and placenta abruptio. So blood grouping and cross-matching is done in both placenta previa and placenta abruptio because all of them need to be transfused. So blood for CBC, HB, platelets count has to be done, and the CBC can tell us a lot in relation to the different blood cells. So we need to do a CBC, we need to do HB estimation, we need to assess the platelets so that we can be able to control the bleeding. Then after ultrasound scan can also tell us what kind of blood product we need to transfuse with this mother. Then besides what kind or what type of placenta abruptio is this mother having. Then besides clotting time, prothrombin time, activated partial thromboplastin time can also be done so that we can be able to know whether this mother's blood can be able to be very important so that we can see are we going to transfuse her with whole blood or we are going to look for platelets to help at least stimulate and support the clotting factors. Are we going to get FFPs, fresh frozen plasma, in order for this blood to help in clotting, or are we going to give her just whole blood packed red cells? So this is very important so that we can be able to see what kind of blood products we need to transfuse with this mother. Then urinalysis for proteinuria to exclude preeclampsia commonly associated with abruptio. So preeclampsia and eclampsia always cause us abruptio plus NT. So when you do urinalysis will tell us the amount of proteins. When you get 2 plus and above, and the mother has other signs of preeclampsia, then you just know this is the cause of placenta and be able to intervene in the management. So what are we going to do after having done the investigations and we have realized that is actually placenta previa? What are we going to do? So you as a health worker, after you've done your investigations, you need to initiate a continuous fetal heart rate monitoring since the fetus is at risk of becoming hypoxic and then also developing acidosis. So you need to do this to make sure that this baby is monitored well so that you can be able to either deliver it immediately to save the life of this baby. So the next is actually for the mother. If possible, put two large bore cannulas, yes, IV lines, so that in case when she goes into shock, you already have those lines. And the preferred gauge is 16, which is the bigger one. So you have to put them, and when you've secured them, you are good to go. You can put a line for fluids and then also blood at the same time, and you'll be able to save both the baby and the mother. So secure intravenous access, place one wide bore intravenous line 6 gauge. 2 if the patient presents with signs of moderate or severe abruptio such as moderate to heavy bleeding, then also hypotension, so that you can be able not to run up and down. The mother is in shock, you can't get the blood vessels, they have collapsed, and you can't access a line, and you end up losing her just in a simple way like that. So when they come and you're able to access the blood vessels, please put those two large bore cannulas so that you can be able to resuscitate both the baby and the mother. Then uterine hypertonicity and tenderness. So you may examine this mother and you see that she has this. So you have to make sure that you reduce this. You can tokalize the mother to reduce the hypertonicity of the uterus. The uterus is contracting and it will increase more pain. And also if the placenta was partially separated, it can even separate completely. So you have also to monitor the fetal heart, continue monitoring the fetal heart, and make sure that the patterns are normal between 120 to 160. Then notify the anesthetist team in moderate to severe abruptio to help in management of hemodynamic instabilities. Hemodynamic instability is when the mother has lost a lot of blood and it has caused a shock and all that. So bleeding disorders and potential need for emergency C-section. So the anesthetist has to be in the team actually managing these mothers. The team has to be multidisciplinary. You need everyone. You need the lab to be informed. You need anesthetist to be informed, the midwife, the doctors, and everyone around has to be alert and participate in the management of these mothers. So when she's hemodynamically unstable or she's in shock, the only way of saving this mother is basically taking her for an emergency cesarean section. So maintain crystalloids to keep urine output to 30 mils per hour. So crystalloids is basically looking at normal saline and Ringer's lactate. So when you give these fluids, you're able to maintain the urine output, because when she bleeds and she has lost a lot of blood, it's going to affect the circulatory system, it's going to affect the renal system, and can even cause acute kidney injuries. So acute kidney injuries is when there is little supply to the kidneys. They are not able to produce enough urine, and the kidneys can fail, and this mother can easily die. And when the mother gets acute kidney injury, it's always very difficult to pick them up. So the normal urine output for a normal person is supposed to be 30 mils per hour. But if this mother is giving you less than 30 mils per hour, then you just know this mother is getting into danger. But for you to maintain this output of urine within 1 hour, then also make sure that you maintain the crystalloids, so that this urine can also be maintained, the kidneys can continue functioning, and we shall be able to save the life of this mother. Then anticipate delivery within 24 hours. Don't push, don't extend. Try to see that this baby is delivered as soon as possible, and to save both their lives, the baby and the mother. Then refer to a hospital if in a health center or dispensary. So I earlier on mentioned that if it is a health center where you're giving only basic care, try to refer this mother as fast as you can, so that this mother can get the right method and intravenous drip and inform the hospital. So if you're referring this mother, make sure that you put a line, the fluids are running, you've informed the hospital. And that's why it is very key to always have contacts of different health workers who work in the referring facilities where we send our mothers, so that before you send the mother to that facility, you first give a call and tell them, I've got a mother with this kind of condition and I feel I cannot handle because I don't have these facilities to manage her, and I'm sending her so that they can prepare for this mother. As soon as she reaches, they are able to attend to her. Then do blood grouping and cross matching before the drip. In case you're able to do this, please do blood grouping and cross matching before you even set the drip. Remove the blood as you're putting the cannula, connect the fluids as the blood is running to the lab for grouping and cross matching. And when this mother goes with these results to the next facility where you've referred her, it will also be very easy for them to actually attend to her in time. So admit the patient when they refer to a small facility. You have to admit her. Call the doctor immediately if in the small facility. So if you are the midwife in the small facility, that is the comprehensive emergency obstetric and obstetric and newborn care facilities, where there is a theater, where there is blood transfusion facilities, and the doctors are there. Please make sure that you call the doctor immediately. As you receive this mother, inform the doctor, I've received this kind of patient, as you are also continuing in the management, running the fluids and doing other investigations if they are not done in the previous referring facility. Then provide emotional support and physical care. Most of our patients end up actually thinking we are not doing anything to them. We are not supportive because we don't provide them the support. But when we talk to them and support them emotionally, keep telling them what we are doing, keep counseling them, telling them the possible outcomes, these people will feel comfortable and they will know that we are really supporting them, and they will always know that they are in the right hands. But when we are moving here, there, and we are not talking to them, they will not understand what we are doing, and they will think we are not supporting them, whereby even what you have done will be looked at like you have done nothing. So provide emotional support and physical care to both the family and the mother. Then relieve pain with IM morphine or you give pethidine. So you can give morphine or you can give pethidine to these mothers. So when you give them this drug, it can help to reduce pain. Sometimes we may not have this morphine, we may not have the pethidine, but we can give them either paracetamol IV, and that is what is common, and uh, maybe tramadol, just to relieve the pain that these mothers are going on during that period of your management. And treat for shock and prepare for cesarean section if severe bleeding. So if the mother is bleeding severely, you have to prepare her for cesarean section, and you know what you are supposed to do. Make sure that this mother consents. Tell her the possible outcomes, both her and the family, so that they are aware that this is the condition of our patient and this is what is going to be done to her, and you can be able to do whatever you're going to do to save the life of this mother without any interference from the family. So treat for shock and prepare for cesarean section if the mother is having severe bleeding. Then frequent vital sign monitoring, whereby you have to look at the blood pressure before you take this mother in, because you may end up taking the mother in when even the blood pressures are unrecordable. The pulse, you're not feeling them very steady, temperatures are below 35, and you're rushing the mother to theater. So you need first to make sure that you have resuscitated this mother, the BPs are almost normal, the pulse before you rush with this mother. And when you get these vitals very well, you can be able to get an appropriate intervention, and this mother can easily survive. Many times we have got some of them, but the interventions have always given back life. Then elevate the foot of the bed to prevent vena cava occlusion by the gravid uterus. So you realize that when the mother is pregnant, the pressure on the abdomen can always compress on the vena cava. And the vena cava is the one that provides a lot of blood, or it circulates more of the vital organs, especially the brain. So when it is compressed, these mothers can end up in shock. So you make sure that you lift the foot of the bed, and when you lift it, it helps to reduce that pressure on the vena cava and the brain. Then maintain a urine output chart below 30 mils per hour, then that is already an indication of a kidney or renal failure. So we have to monitor the fluid chart, where we need to know their urine output, and also we have to know the input, and also we need to know the test of the urine, so that we can be able to know if they are urine, and if there is of eclampsia, preeclampsia, which could have caused placenta abruption. Monitor blood for coagulation defects and clotting time. So when the blood fails to clot, that is already a very, very big problem. Because you may take this mother to theater and the blood fails to clot, and she will bleed and die. So what you need to do, you have to monitor the blood for coagulation defects and clotting time, so that you can be able to know what intervention are you going to give to this mother that can help you save the life of this mother. So labs are very, very vital for you to do them before you enter this mother into theater, so that you can be able to gauge how long are you going to carry out the Caesar, because the faster you are, the better. And also the type of blood products that you're going to transfuse with this mother can also be one of the contributing factors to help you support or actually save the life of this mother. And also it can help you save the different types of drugs that you're going to use to help you in improving the clotting, to reduce the blood loss. So it's very important for you to monitor the blood for coagulation defects and clotting time, and that's why we talked about also the CBC, so that we can be able to know the platelet levels, so that we can be able to actually plan for the proper intervention. So prepare for the reception and resuscitation of the baby. Very well, we know the babies depend on their mothers, and basically the nutrients, the oxygen, and everything is actually provided to the baby from the mother through the placenta, and it is delivered by the cord. So when there is low blood in the mother, that means also the baby has been deprived from oxygen and nutrients. So when this baby is delivered, the majority of them end up with hypoxia. They end up with um, fetal distresses, and when they are delivered, they come out when they are not breathing, and you have really to be prepared for resuscitation. And also, most of these mothers who bleed, we don't give them a spinal anesthesia, but we give them a general anesthesia, and in most cases, also these drugs can affect these babies. So when you go to receive this baby as a midwife, you really need to be prepared on the resuscitation bit of it so that we can be able to save these babies. Otherwise, the golden minute is very key. If you don't intervene within the golden minute to secure the breathing, then you can lose these babies. So our blood transfusion is very, very necessary. And having mentioned about the blood products, we need also to know what type of blood products do these mothers need, from our labs. So that will direct us on how to intervene on the blood transfusion bit of it. So if the mother is hemodynamically stable with cervical dilatation more than 7 centimeters, or in second stage with no contractions to vaginal contraindications, and allow the mother deliver vaginally with close monitoring. So we can vaginal bleeding, hemodynamic state, you have to deliver the emergency nurse section. So you need to perform bedside ultrasound scan to determine the presence of abruptio placenta. So if delivery is remote or more than 1 hour, remote meaning if it has delayed and it is more than 1 hour, you have to proceed to deliver by emergency and what section. So you can realize that this mother has to deliver within 1 hour's time. So you cannot wait for this mother to labor. You just need to hurry to deliver her, and this can be an emergency section. So prepare for neonatal resuscitation, refer to neonatal resuscitation section, and this baby can be handled in much better in the neonatal unit. So if there is no contraindication to vaginal delivery and the mother is hemodynamically stable, then you have to rupture the membranes, augment labor with oxytocin, and you deliver this mother. However, if the condition of the mother is deteriorating, proceed to deliver by cesarean section still, and then anticipate and prepare for PPH due to atony and the covalera kind of uterus, because most of these mothers end up with PPH and they end up also with the convolvulus kind of uterus because of that blood that has enclosed onto the uterus. It makes it weak and ends up failing to contract, leading to PPH. Conservative management for mild placenta separation, you have to do intrauterine scanning and continuous fetal monitoring. Then if mother and baby are well and gestation is under 37 weeks, you discharge, and weekly antenatal clinic visits are advisable. This mother should always come for antenatal every week so that you can be able to monitor this baby. Then at 37 weeks, readmit for induction, and if needed, you can do a cesarean section. Here are the clinical factors of placenta previa versus abruptio placenta. We are supposed to understand or to know the difference between placenta previa and then placenta abruptio. So history, warning, bleed, and then less likely to bleed. So we need to know which one is for placenta previa and which one is for placenta abruptio, so that when you understand them, you can be able to differentiate the different signs and symptoms, and you can be able to tell the different types, the different type of APH. Is it APH caused by abruptio, or it is APH that is caused by previa? So that we can be able to handle them in relation to the diagnosis we have identified following the signs and symptoms. So the complications of abruptio placenta, each type of APH has its complications. So blood clotting failure, and then also it has renal failure, having mentioned about the 30 mils of urine per hour. Sometimes they end up having less than 30 mils per hour, and this can cause renal failure. Then pepperosepsis can also occur both in abruptio and the previa. Then anemia is in both because there is loss of blood in both. And then maternal and fetal death occurs in both because we know blood, when we lose a lot of it and it is not replaced very fast, or no intervention is done immediately, there is loss of life for both the baby and the mother. Then anterior pituitary gland necrosis may occur in severe bleeding, and this can occur in the mother. And most of them have gotten those complications due to delayed interventions, and some of them have ended up actually not being managed well, and some of them end up with mental complications. They get disoriented due to this kind of impact onto the anterior pituitary gland. And then secondary infertility due to subtotal abdominal hysterectomy or total abdominal hysterectomy, because when they fail to contract and there is serious PPH, postpartum hemorrhage, they end up removing the uterus, and this causes secondary infertility. Then intellectual disabilities, this is both the baby and the mother. Most of these mothers have ended up having intellectual disabilities, and yet if they handled very well, as soon as they realized that they were bleeding, they were going not to have this kind of complication. So some of them have ended up in these disabilities, and even the babies. Then developmental delays in the baby services. Sometimes our babies end up with cerebral palsy because they are not cared well, or else they end up with some other complications besides the cerebral palsies, and most of them have failed to grow, and they remained in some stage where they cannot walk, they cannot sit, and causes problems to their families, and a lot of loss of resources in trying to manage and save these babies. Then preterm and prematurity deliveries. Some of them have ended up delivering premature babies because when the placenta separates, the mother cannot continue with the pregnancy, but the baby has to be delivered. So preterm and prematurity deliveries are also common due to abruptio placenta. And that is the end of our session for today. Basically, we have handled APH, that is antepartum hemorrhage, and antepartum hemorrhage is caused by majorly two conditions, that is placenta previa and placenta abruptio. And we said placenta previa is when the placenta is low-lying. The placenta is located or situated at the lower segment of the uterus, and we mentioned about the different types of placenta previa, and we said type 1 and type 2A can be delivered normally, but type 3 and 4 cannot be delivered normally, and those are like an emergency conditions that can be delivered by C-section. Then we talked about the different predisposing factors or causes to placenta previa, and then we also talked about the management. We also went to abruptio placenta, where we said it's a premature separation of the placenta, where the placenta separates before the baby is born, and they talked about the different possible causes or predisposing factors to abruptio placenta, and we talked about the management of placenta abruptio. We talked about the differential diagnosis in both of the conditions, and some of them cut across. We also talked about the different lab investigations that we should do to help us manage these patients or these mothers. And we mentioned about the CMOC facility, where they provide comprehensive emergency obstetric and newborn care, and those ones comprise of health center falls here in Uganda, whereby you find a theater and you find the doctor, and you're also able to provide blood transfusion services. And then we also talked about the basic, that is the BMOC, where we only give the basic services to our clients, and we are not able to provide theater services. We are not able to blood transfuse, that is like in health center 3s, health center 2s, because they don't have the doctors, they don't have even actually scanning services which can help us diagnose. Then we also talked about the comprehensive management of abruptio placenta, and we ended up with the complications of placenta abruptio, but also there are different signs and symptoms that can help us differentiate how abruptio placenta mothers can present and how placenta previa mothers can present. So when you're interfaced with this condition as antepartum hemorrhage, where you look at abruptio, placenta, and placenta previa, I believe you can be able to differentiate which patient has come and she's having abruptio, which one has previa, and how am I going to handle these mothers. So I believe we shall not lose our mothers because of APH, because now we know that this is an obstetric emergency. If you're not able to handle her at your level of a facility, then please immediately refer this mother to the next facility. So thank you very much, and this is the end of our session today. Bye bye.